Welcome everybody. Thank you for coming. This is a bit different. This is the first hour, which is usually for the senior residents, so less formal. I know there's people at Harborview also, and then the more formal grand rounds will be the next hour. So I thought, just as an informal introduction, thank you, Dr. Bernat, for joining us. This is really wonderful. It's been a lovely day with you. Dr. Bernat is a professor of neurology and medicine at Dartmouth. And I will tell you a little more about him later. The tidbit that we have now is that he went to elementary school in Finneytown, Ohio. Thank you.
Let's see, I was told to put this on. Let's see. This is a test of bimanual dexterity. Good. Claire, thanks very much. I think that's the first time in my many introductions that anyone has ever mentioned that little fact. I mentioned to Claire that I was back there for my 50th high school reunion recently, so I've been thinking about it. Anyway, it's a real pleasure to be here today, and my main talk is going to be later on the controversies, conceptual controversies in death determination. But I was asked to talk a little bit about the observations I've made about the electronic health record that formed the basis of an article in Neurology a couple of years ago that had this title, and some comments I made at the presidential lecture of the AAN in April of last year. So I'll talk a little bit about some of the ethical and quality issues in electronic communications, focusing on electronic health records, abbreviated EHR, and a few words about email and social networking. This is not going to be a very long presentation, certainly no more than 30 minutes, so we'll have time for discussion, or maybe commiseration might be a better way to put it. The history of electronic health records, there were homegrown versions of these. I know the Dartmouth programmers put our clinical information system together in 1991, and it was, in retrospect, a pretty good system. We all liked it. It was primarily outpatient, but it also was integrated with the inpatient service. It didn't, however, do billing, nor did it do electronic order sets. There was a need for a more modern form, and it was stimulated further by a federal act called the High-Tech Act of 2009, and that stands for Health Information Technology for Effective, for something in clinical health. Now, what's the E? I don't remember. Doesn't matter. It's a health information technology. And it incentivized hospitals in medical practice to convert, sorry, that should be electronic health, EHR. Each time I type that, my helpful Microsoft Word spell check changed it into HER. I must have missed that one. And it led to a 70% adoption rate by the year 2014. One of the interesting things I learned was from this wonderful book that I cite here at the bottom by Robert Wachter from UCSF called The Digital Doctor. I reviewed this for Neurology Today a couple of months ago and learned quite a bit in it. And he had a nice history of electronic health records. He pointed out that the High-Tech Act of 2009 contained technical requirements for the vendors, but the technical requirements didn't include a lot of quality issues, such as things that required different vendor systems to communicate with each other. So we ended up with this Tower of Babel situation where we have different systems that cannot communicate with each other. That wasn't required, so the vendors didn't do that. And there are a number of other quality issues that similarly weren't required and therefore weren't part of the system. And then, of course, there was a parallel program called Meaningful Use that Congress mandated as a companion to this. And meaningful use has gone through 3 stages. Stage 3 is coming up. In stage 1, from 2011 to 12, it required that medical professionals and hospitals use electronic health records and record medical data electronically, and that went through relatively simply. Then we started getting into trouble with stage 2 because with succeeding stages, the congressional mandates became more prescriptive. And in stage 2, it required, in order to get the incentive payment for meaningful use, it required that 17, quote, core objectives, unquote, be met. And many of these were impossible. For example, one of the core objectives was that at least 5% of all discharge summaries would have to be sent electronically. And the majority of the patients at the time of discharge, the majority of the patients went to either nursing homes or rehab centers upon discharge when they went to a different facility, that is. But those facilities didn't have electronic health records. So there was no way that you could electronically transmit it. Sure, you could print it out and mail it or send it with the patient, but that didn't count. It had to be electronically transmitted. And there was a number of other ones that Wachter talks about in his history of this that were impossible to do. And now stage 3 is coming up, and it has replaced the core objectives, or added to the core objectives, with 8 key objectives, then, for example, involving clinical decision support that are more prescriptive. And these are now out for public comment, are not finalized yet, so we need to stay tuned about this. In this paper in the New England Journal last year by Walker, looking at what the impact was in the first 5 years of the HITECH Act, when there had been widespread implementation of electronic health records, Walker and colleagues concluded that neither the cost savings nor the efficiency expectations had been fulfilled. And that all of these great promises that had been made with that what would happen in terms of saving money and increasing efficiency had not yet occurred. So the overall impact in clinical care remains to be seen. But what I want to talk about today is a different set of problems that have to do with ethics and quality pitfalls. But before I do, let me just enumerate some of the benefits of these, at least as I see it. Instant access and transportability, prescribing accuracy and prevention of adverse drug reactions, ease in reviewing labs and radiology, the electronic order sets, which I think on balance are beneficial, billing documentation, to which I added an asterisk because that really has been the main stimulus that many medical centers use for converting fully transparent medical records, which I think is good, and for patients to have access to these and to see the results of their labs and x-rays and other things. And then this final one that I think is potentially a very powerful good byproduct of this is that the electronic health record can be mined and then the data from them compiled on routine clinical experiences. That means the day-to-day medical care that we all give our patients and use for comparative effectiveness research to create what has been called a learning healthcare system, and that is that what we do and our experiences taking care of our patients, instead of being purely clinical, can be used in a quality improvement, if you will, or even research, some call it, learning healthcare system, where some of the demographic data or patient selectivity data, such as genomic data or age or comorbidities and so on, correlated with how they respond to different drugs, can be used to learn things in comparative effectiveness. The leader in the neurology community is Jim Maraganore from the North Shore hospital systems, the North Shore one in Chicago, on the North Shore of Chicago, who published a nice summary of their current status in the current issue of Neurology Clinical Practice that I've cited here. This is a very exciting, I think, potential use of this, although it raises some consent issues, which I'm involved with in our own medical center and be happy to discuss later. But these are basically the benefits. And the liabilities are numerous, and I probably don't have to tell the audience here about these because you've seen it in your own observation of electronic health records, perhaps from your own institution or from others. The ease of copying and pasting has led to rampant inaccuracies. There can be ambiguity of authorship of notes that can be started, kept in a pending format, and then completed later, but it isn't clear what was recorded when and by whom. That is a problem, particularly in training situations. There are templated note inaccuracies, there are checkbox inaccuracies, what I call the pseudo-history, pre-populated data problems. And I'm going to talk about each of these a little bit. Impediments in the office to the patient-physician communication and harmful transformation of medical care. So the copying and pasting, all of us have seen cases in which clone notes have been made. We may have made some of our own by copying a previous note and pasting it and using it, for example, as an inpatient progress note. This is quite common. And there's nothing necessarily wrong with it as long as the data that remain on the fresh note have been reviewed, updated, old data are purged, and new data are entered, so that the time-saving part of it doesn't suffer an inaccuracy. It's simply bringing forward material that is still current and accurate, but getting rid of old bad stuff, old stuff, and putting the new. The problem is, and it's been shown in the clone note data studies, that that is not done. And this was a paper published in Critical Care Medicine in 2013, looking at the prevalence of copied information by attendings and residents in critical care progress notes. And those of you who didn't see this would not be surprised to learn that it's somewhere in the 75 to 85% range of cloned progress notes in an ICU situation. Now, as I said, the solution to that is assiduous accuracy. And the copying and pasting per se is not so bad as long as it's your own work. The copying and pasting is a problem when you copy somebody else's work. And that is a more serious problem, I think. I've certainly seen, I'm from the old school that takes a detailed social history, interested in the patient, and there's where they were born and raised, and where they went to school, and what jobs they've had, their family life, and so on. And I've seen my paragraph of that in a lot of different notes on my patients when they're seen by other doctors. They simply copy it and stick it in the family history, and in a way, that's flattering, I guess, but it's wrong to do that, obviously, on several grounds. One of them is that it may perpetuate inaccuracies. Maybe I have some errors there, and those would get perpetuated. Another one is plagiarism, that is, without adequate attribution. It's taking someone else's work and attributing it to yourself. And also, it is the failure to do what a doctor should do in the first place, which is to take an adequate history yourself. So that is, I think, a bigger series of problems. The ambiguity of authorship I mentioned, the templated notes. I use a template on some notes. For example, I produce a normal neurological examination and can download that and then go through it line by line and take out the parts that don't fit and leave in the parts that do, and it can be time-saving. And I think as long as it is accurate and it may save entering certain data, it's okay, but the same problem pertains to any copying and pasting as it does to templating, which is the carryover of incorrect information. And we've all seen this repeatedly. In fact, one referring physician, a primary care doctor in our community who sends us patients, when I was speaking at a community hospital about this, raised his hand and said, that one of the doctors in our own institution, a gastroenterologist, when he sends endoscopy reports, they're all basically the same. That is, different patients all have the same report, and he thinks that that can't be quite right. The checkbox inaccuracies, some of the electronic health records create a history as a result of checking off boxes, as a result of asking a patient a yes or no question. So if you're doing one for gastroesophageal reflux, it might say if you had heartburn or chest pain. And if the answer is yes, and the doctor going through it can just click the box, and then at the end, each box is transformed into a sentence. The sentences are gathered into paragraphs, and the paragraphs into a history. And at the end of the series of check boxes, the history occurs. And I've called that a pseudo-history because if you read through it, it has a pre-formulated words that aren't quite what the patient said. And yet it appears that it is what the patient said. And it creates a lot of mischief. And it led to this editorial a couple of years ago in the American Journal of Medicine decrying the practice of check-the-box medicine and, again, leading to rampant inaccuracies and misleading histories. There are problems with pre-populated data. Many people use this very helpful feature, which is you can click and get the recent labs or radiology or some other things. And that's very nice to be able to have those in your note. We had a couple of cases that were brought to my attention of people at the time of discharge summaries who had a recent lab that was done on the day of discharge with critical value that was in the discharge summary, and no one saw it. So the pre-populated note allows you to put this in there, but it doesn't require that you read it. And one of the things that interests me is what are the unique features of electronic health records that were not also present in the paper record era? For example, you could still write a sloppy note or copy somebody else's work in a paper era. But what you couldn't do was have something either dictated or handwritten or typed in a discharge summary that you hadn't at least been aware of, because you had to put the result in there, whereas the pre-populated data allows you to do that. The very serious problem is the impediment to the physician communication, and this has been studied extensively by a number of people, and has also been decried in this article in the Annals of Internal Medicine, in which they analogized doctors entering data in the examination room of the patient sitting there to which they call texting while doctoring, to analogize it to texting while driving, which everyone knows creates a huge liability for accidents and a safety hazard. And they said this was the equivalent safety hazard within the medical field. And it led to my failure to attend to the patient, not seeing the patient's reactions and gestures and the unspoken forms of communication that are such an important part of communication, and the patient feeling that you're paying attention to the patient rather than you're paying attention to the keyboard. And I'm sure all of you have had the experience of hearing patients complain about other doctors who seem more interested in their data entering than in them. This was studied in a number of studies, and this is one of the earliest ones, 9 years ago, in which they measured the effect of data entry in the exam room on the interaction with the patient. And in this study, the physician spent 25% of the visit gazing at the computer screen, and in some cases, that was the average. And in some cases, it was as high as 42%, with heavy keyboarding in a quarter. And that, not surprisingly, the amount of keyboarding was inversely proportional to the amount of dialogue, because it's hard to do two things at once. And the quality of patient-centered communication was similarly inversely proportional to the percentage of screen gazing. This was a crayon drawing of a 7-year-old girl published in JAMA a couple of years ago in a brief article. in which she accompanied her mother to a doctor's appointment. And while the doctor was typing into the keyboard over here, and the mother was sitting on an examination table here, and the girl was over here, drew a picture, a pretty good picture, of the goings-on, showing the doctor in this old style, not only not looking at the patient, but not even looking in the direction of the patient, but looking against the wall. So I think that the impediment to the patient-physician communication and relationship is easy to understand. But I think the most serious problem is the transformation of clinical care, which I call the most pernicious liability. And it's basically led to a social change, which I don't think is hyperbolic to say it's a corruption of medical record keeping, which traditionally was to record a medical encounter, but now it's a tool to justify billing codes. And the data that are recorded are specifically targeted toward billing, so that the medical record, rather than being a record of a medical encounter, has become a billing tool, and it's that billing need has subtly shifted our practices of what we do, or at least what we record, which may not be what we do, but toward billing documentation, and it's a profound professional transformation that has been the source of a lot of commentary. I cite here Paul Starr's wonderful book from 1982 called The Social Transformation of American Medicine. Starr is a sociology professor. He's been at Princeton for years, but was at Harvard at the time that he wrote this book. And for those of you who didn't read it, it's a classic. It studies the history of American medicine up to around 1980 and talks about a transformation toward corporate medicine and the power of insurance companies and so on. And even though he's written a follow-up book about recently, it doesn't, I'm calling what's going on part two of the social transformation, where the medical care elements that are necessary in the examination are being dictated by insurers, particularly Medicare, and secondarily the private insurers, who tend to follow Medicare's lead. And the purpose of the record is now billing. Quality has been replaced by quantity because they count the number of bullets toward whether it satisfies the criteria for a particular billing code. And those of you who have looked at hospital discharge summaries and emergency room notes know, as I do, that the relevant information has been lost in a morass of detail with rampant inaccuracies and harm to patients. And I use the expression that it has all of the parts, but it's missing the whole, meaning that it's hard to get a sense, looking at it, it's hard to get a sense for what has gone on in the patient encounter. And not to be too nostalgic, but I think that when I was a resident in the 1970s, part of our job was to learn how to take all of the information, distill it down to the essential stuff, dictate or type out, we dictated that, the history, the examination on admission, the relevant laboratory and other objective data, the assessment, and then what the plan was and what happened to the patient and what the follow-up was. And by reading a few pages of this, the reader could get a pretty good sense for what took place. I defy anyone these days to do that. Now, there's nothing about, and I've seen excellent discharge summaries by our better residents. There's nothing saying that they can't do that, but the way that things are done with cutting, copying and pasting fragments of data in this, it makes a pastiche that, as I say, has all the parts, but it's missing the whole. Now, the rounds have followed this, and this is, of course, an exaggeration, so forgive me. Then and now, with rounds and rounds now being around the laptops. But studies have documented this, that this was published in the Journal of General Internal Medicine in 2013, and it was an inpatient time study of medicine interns, or if you prefer, PGY1 first-year residents. And this is one of these things where they follow people around with a little stopwatch and a clipboard, and they see, even when they go to the bathroom, they follow. And they found over a several-week period that the direct patient care, meaning face-to-face with the patient, occupied 12% of their day, of their duty time. Patient care, indirectly, was another 64%. So it wasn't that they weren't doing things related, but it wasn't with the patient, in presence of the patient. It included reviewing notes, writing notes, talking with the team, paperwork, orders, handoffs, and so on, rounds. And 15% of their day was educational, and then there was 9% other stuff. So looking at direct patient-to-patient interaction, it represented a fairly small minority of the total time and a small fraction of the total patient devoted time. In a related study published last year in the American Journal of Medicine, the authors looked at how many hours third-year clinical clerks during their clinical rotation spent with electronic health records, reading them or writing in them. And you see internal medicine, family medicine, psychiatry up there. Neurology is over here on a little bit under 3 hours a day, so it's less than half of internal medicine. I guess that's better, but it's obviously a large portion of the day. It isn't only data, but personal accounts about this, and I show this picture of Bud Relman, the former editor of the New England Journal of Medicine, who published a fascinating essay in the New York Review of Books a year and a half ago, shortly before he died, talking about his illness, which eventually became terminal when he was running for a taxi from his home on Beacon Hill and tripped and fractured his neck and was admitted to the Mass General. And he wrote this, and he submitted this photograph that was taken of him with Marcia Angel, his wife. It was published in, and nothing I'm telling you is private, it was in the article. And one of the reasons for this was that he made a series of observations as an academic physician, one case report, his own, and it was, I think, worth reading. And he remarked that the physician spent most of the time away from him and other patients reviewing and discussing the data. They were very interested in his data more than in him. The rehab he was critical of, but that's not relevant to this. He then looked at his medical record, was interested in what they had to say about the progress notes, and he noted that there were very few descriptions of his examination or even how he looked or what he said about how he felt, but many notes about his data, his x-rays and his labs and scans and so on. And most of the interaction, the personal interaction, was done by nurses and therapists. And there was generally a lack of anyone overseeing his care who communicated with him. Now, maybe because he was an exalted academic leader, he intimidated people, although he didn't strike me as a particularly intimidating person. One could imagine that might happen, but I think that that was a relevant series of observations. Well, what sort of correctives might be done here? Choosing the electronic health record with an optimal features. I've been very critical. I think the incredible cost. I was at a meeting last week with, we had a regional medical neurological society meeting, the Northern New England Neurological Society, and we invited all the Dartmouth people that had ended up at the Mayo Clinic, and 4 of them came back, which was very kind. And they had just implemented Epic, and we've had Epic for 4 years, so there was a commiserating about that. And one of the points that I made about it was that with the fantastic cost, I thought ours was out of sight, but their 3 divisions cost them $1 billion with a B. That's what that costs for Epic, all the implementation. Now that's not just direct payment to Epic Systems Incorporated, but that includes all of the startup costs and the teams and the implementation and stuff. Despite the fabulous cost, The quality of the product, I think, is not that great, and I think could be much better. I think we should resist temptations to take harmful shortcuts and maintain accuracy when copying and pasting and using templates by careful editing, and takes time. Designing office setups to maintain line of sight, considering electronic scribe, not a good idea for neurology, I don't think, but for some fields. I know when I go for my annual dermatology check, skin check, they use a medical scribe, where the dermatologist goes around and someone's in there, some other person is hired to keep notes. And working toward enlightened reform of reimbursement documentation regulations, because the Medicare regs are these quantity versus quality things, that it requires all of the bullets, including totally irrelevant information. And when you're required to put down irrelevant information, you lose time for relevant information. I'm going to skip the email and the other stuff to just end, because I've taken more time than I thought I would. I want to say just a few words about Burnout. Bruce Sigsbee, the now past president of the American Academy of Neurology, the Dartmouth guy, and I wrote this, he wrote most of it, but this paper on burnout in neurology that was published last fall. And it's become a big deal now for the American Academy of Neurology, because the data show that among specialists, the rate is, neurologists are very high in the order of physician burnout. It's higher in primary care for obvious reasons, but among specialists, it's very high in neurology. And of course, it's the emotional and physical exhaustion, depersonalization, meaninglessness of work. And one of the factors that makes it relevant to this discussion is that when physicians are forced by regulation or circumstance to do either substandard work by not having enough time for us to do a proper neurological examination or assessment, because there's a demand to see too many patients in too short a period of time, or meaningless work, such as unnecessary electronic health record documentation, leads to frustration and dissatisfaction, and can lead to physician impairment, which may lead itself to premature retirement, depression, substance abuse, and even suicide, and to substandard work product endangering patients. And the prevention strategies that have been described in this nice review from Mayo Clinic proceedings, where they recommend creating a quality indicator for physician wellness. There was originally a paper in The Lancet in 2009 about this, but they picked up on that we have all of these quality indicators that are being measured about in diabetes, how often you order hemoglobin A1C concentrations, and so on. Well, why not a quality indicator for how well the physician is doing insofar as physician wellness directly impacts the quality of the care that's given to the patient, and to elevate its importance to that of other quality metrics. And I think that's a very reasonable idea. And if that were done, perhaps more attention would be given to promoting physician wellness. We're at our medical center, we have the Dartmouth Institute for Healthcare Research, which does a lot of national work on healthcare theory and practice, and it's one of the leaders for the Accountable Care Organization movement. And it provides an opportunity to incorporate physician wellness processes into the redesign of physician workflow in accountable care organizations. So this whole thing is being rethought about how workflows should be designed, and we want to prevent busy work and meaningless or substandard work, and that there's an opportunity there, and to establish programs of self-care. And this is the paper that Bruce wrote with my minor inputs, published last fall. And as I said, Bruce is taking it upon himself to make sure that the AAN has a physician burnout program for neurologists, because he sees it as such an important problem that our major professional organization should be all over it. And he's doing this. And what he suggests was physician counseling, individually or in groups to provide adaptive skills to help doctors, avoiding meaningless tasks and reducing hassle factors of insurance mandates, redesigning the practice, and mentoring to try to reduce time pressure, and creating a culture that fosters personal growth and recognition of accomplishments. So I'd like to end there and leave time for some discussion. Thank you. I wanted to make this interactive. So be happy to hear comments of people from various walks of life about their observations about electronic health records. Yes?
So you indicated that there's some estimates that 24 to 40% of time in a clinic visit, the physician spent typing or looking at the computer.
This was that one study that I cited, which was an early era, and I think there's been a lot of effort to redesign to align the line of sight with the patient. In other words, the idea of facing a wall is ridiculous.
Right.
Everybody knows that's not a good system. So the idea, and some of the advocates have said to me that if you do it well, it isn't that dissimilar to what I do, which is sit with a pad of paper in my lap with a pen and scribble some notes. It could be done in a similar way.
So that was by the patient or your work product? Sorry, Chris.
No, I'm sorry. What was your?
I mean, I think that you could have a similar quality of work product with a nice line of sight, and it's a little more friendly. But I think patients still don't like. If you survey them, I don't think they like to.
Right. Well, the problem is that myself, many people, other than my wife, who's a very good touch typist, I can't touch type. I took a course, but I couldn't do it. So I look at the keyboard. Otherwise, it's really terrible what I get. But there are people who don't need to look at the keyboard and can look at the patient and touch and do a pretty responsible job by touch typing. I think that if you could do that, I can look at the patient and write fairly well.
So that was my kind of follow-up question. Were there any estimates of what percentage of time physicians were spent writing during clinic visits?
No, I haven't seen. Does anybody know that? If that's been studied? Probably somebody's looked at that.
Well, I think the notes were so much shorter and more direct that I imagine must have been
I mean, when I take notes, they are notes. And they're not full sentences, and it's not the finished work product. I think when people are doing this, they're hoping that that's it, that that's the history. They're not taking notes while they're doing that. Now, maybe they may want to go back and edit it a little, but it's basically the finished work product.
Is there a requirement for billing and so on that the inpatient progress note has to have all that garbage?
I'm not on the inpatient service anymore, so I'm not exactly sure. I haven't looked at the Medicare regs for inpatient billing criteria, but I would imagine that they have similar bullets to the regs for outpatient, which I am involved in. So I would say yes, there have to be certain elements that have to be present to count as a. Does anyone know the answer to that?
I think more is in our typical note than needs to be. I think that's true. But the elements, that's a problem, is probably none of us know exactly which ones.
They're
Jim?
who get paid for looking at that stuff, and there are definitely bullets, and there are definitely very specific requirements for inpatient.
And it like the outpatient, even if you did an adequate note that said, patient resting comfortably, no new patient examined, no new signs, labs normal, or something very quick that might be clinically adequate, it would be totally inadequate for billing. Totally.
The way in which you can see this actually is in places like our house at Northwest, where we don't have an electronic inpatient record. But in order to meet that requirement, the reason I know this is true is because they've created handwritten templates where there are a whole bunch of boxes that you have to check off, which makes so that if you look at a two-page note, it's a progress note. Imagine that, 2 pages of progress note. At least 50% of the space is occupied by boxes that are checked in order to meet billing requirements and in order to get least a 99232 out of it.
No.
Why didn't somebody require readability somewhere?
It probably wasn't a high-tech thing, but no, Medicare, I mean, they have decided that the billing codes should be based on the amount of work that the doctor does. And the amount of work is proportional to the number of elements of, you know, the old expression, if it isn't written, it wasn't done, which isn't true. I mean, we've seen a lot of stuff written that was never done. But that's just the way they do it. Tom first.
So I wanted to follow up on that point because I think something happened. I don't know if it was in the 60s, 70s, or 80s, and part of it was a mistrust. Institutions, maybe it was Medicare, maybe it was insurance companies, maybe it was patients, I'm not sure. But they developed a mistrust that doctors were billing for things they didn't do. And the concept became, what are they supposed to be doing? And some simple things started to happen, but few things, as far as I was concerned, way out of whack. For example, a doctor bills for a physical exam. And did he really do it? It wasn't clearly documented in his notes. So somebody went to a physical diagnosis textbook and said, what is a physical exam? And they just started looking. Well, you've got to look in their ears. You've got to look in their nose. You've got to test their sense of taste. And if you haven't done all of those things, you haven't done a physical exam, because this textbook says that's what a physical exam is. And so the requirement began to develop these checkoff lists and checkoff boxes to document that you actually were doing what you were billing for. And it came from this sense of mistrust, that you couldn't trust a physician for saying what he did. And then it got miscued because physical exam varies from time to time and patient to patient. And if a physician did every element of a physical exam in a textbook of physical diagnosis, it would take all day. We know that. And so, but there was a lack of trust that you couldn't accept the physician's word that he did the appropriate part of the exam, and that's what he's billing for.
Well, that's a very interesting history, and it's doubly ironic because a lot of things that are written, they never did, and it hasn't solved the problem, it's probably exacerbated it.
This was also done, part of it, that was a segue, but the question I wanted to ask you, the history of this, you know, the E&M coding system is a proprietary thing that is owned by the AMA. And all of the things that we're talking about with that coding system is something that was done with the complicity of the medical establishment, medical profession. And I don't understand quite how that happened.
Yeah.
Because it is, in fact, I mean, the government, anyone, the government, I like the government, but whoever it is, the insurance companies, whoever it is, can say, well, this is something you brought upon yourselves. You designed the system. Because we did, somehow.
Yeah, Claire?
Yeah, I don't know. I have a friend who's worked a lot with consulting businesses, and he says these electronic medical records are a consultant's dream. Because nobody quite gets them, everybody has different systems, and we have to bring in these consultants to help with them. And so, you know, if we all had one system, for example, we wouldn't need as many consultants for it. And I just find it fascinating how, you know, most of us don't really know what we're exactly doing and why we're doing it and how we're using something.
We have a couple of questions on the board here.
Oh, thank you. I'm not used to using that. It appears that a system is created for people read this. It appears that a system is created for physicians to follow. They are following it but feel powerless to change it. What do you propose of a way to regain some of it to bring insanity? Yikes. I don't know. I don't have any particular answers, but I think that the quality part of it needs to replace quantity somehow. The problem is that how do you measure it? Everybody wants to measure things. And it's easy to measure parts of things. That's a tangible, discrete entity that somebody can scan it and count them. But how can they, by reading a note, divine the quality within that interaction? It's not simple to do that. So I think that's one reason that they focus on quantity rather than quality, because, I mean, it certainly isn't the quality indicators like hemoglobin A1Cs and that sort of stuff. That's a surrogate. The second one, Medicare and other insurers do accept as an alternative to bullets to saving counseling constitute over 50% of this 25. That's true. That's sufficient for billing purposes. And as neurologists, much of what we do with counseling and medication planning, etc. Yeah, that is true. One has an option of doing the billing based on counseling rather than the bullets. I think what our coding people implied to us is that if we began to do that routinely, that would trigger some kind of look-see, an audit or something. And there are specific criteria for that also, counting the number of minutes of the total encounter, the total number of minutes that counted as the counseling part of that, writing that down. That's necessary for billing by time. But that is an alternative, and I use it sometimes, but I'm been intimidated against using it more routinely. I don't know that that's true, that it would trigger an audit, but it might. John?
I don't do it because I can't stand reading it in other people's notes.
Yeah.
I was going to ask you about the corollary to the EMR is the patient communication piece, and it seems to me that that's really gone up exponentially since EMR has become vogue. And there's both good and bad in there, but one thing that it seems like there's a lot of our work now is now not when we're in the clinic.
So you're talking about email communication?
Yeah.
Yeah, I did skip that part only because I didn't want to take up a whole hour with it. But yeah, it's obviously a mixed blessing, and I think it can be abused. It is useful, at least in my practice, where I take care of a lot of chronically ill patients who live a distance away, and it can be hard to get in the winter, for example, in for an appointment. It allows continuity of care so they can stay in touch. I would say that, like most things, it's only a small minority of the patients that abuse it, and most people are responsible. They know doctors are busy and they don't want to feel like they're monopolizing your time. But there are a couple that do. And one of the virtues of it, I think, is that you can, my standard is if I give advice, if I start a medication or change the dose of the medication, I create a note out of it by copying and pasting the patient's email and my response to make a note, an email note in the electronic medical record, which I think is important. And one of the virtues of that note is that it has the patient's symptoms in their own words. Similarly, I'll have patients send me an email before a visit with a summary of their observations. And I'll just copy and paste that and put that in the subjective part of the note as their own statement of their. It was very simple to do. It takes a few seconds. And it renders it without my filtering it in their own words. So I think on balance, it's probably better, but it certainly adds time. Yes.
So it seems like there are many people who are distressed by the changes or by how the EMR is getting implemented, the EMR industrial complex, and then putting money in the pockets of consultants. So is the AMA, are there legislative processes that are being pursued, or is this even a topic that some cohesive group is trying to put forward?
Yeah, the question is whether, given the recognition that this is a serious problem, are the medical societies like the AMA doing something about it? And it's a good question. I don't know the answer. I would imagine that somebody's doing something, but I'm not on the inside of that, and I just don't. Does anybody know the answer to that? As I said, the AAN is doing this thing about. What?
We were all hoping you were.
The AAN is certainly doing the thing about the burnout, and to the extent this contributes to it, I think they may want to do more. But we should probably take a little break between now and 4:30 when the next round starts. Is that okay? Good. Thank you very much.